Welcome to ASRS's Journal of Vitreoretinal Diseases Authors Forum. I'm your host, Dr. Timothy Murray, Editor-in-Chief of JVRD. On each episode of the JVRD Authors Forum, I will interview innovative retinal researchers on their studies featured only in JVRD and how these studies will impact our patients' care in our clinics. Tune in to hear directly from investigators about the clinical implications of the newest and highest quality research in the field of retina. Welcome to JVRD's Author Podcast. I'm pleased to be joined today by Dr. Avni Finn, who is an Associate Professor of Clinical Ophthalmology and Visual Sciences at the Vanderbilt Eye Institute in Nashville. We're going to discuss her manuscript, Risk Factors for Macular Hole Development After Pars Plana Vitrectomy for Rhegmatogenous Retinal Detachment. Welcome, Dr. Finn.
Thank you so much, Tim.
It's a pleasure to have you here. So I think this is fascinating because those of us that are surgically active, all of us have had this occurrence. So can you tell me a little bit about what drove you to this idea of the manuscript and how you developed that for your publication?
Sure. So I think you hit the nail on the head. Like many of us, a lot of the ideas for my research come from patients I'm seeing in the clinic. And I had a patient who I did macular hole repair. Had a macular hole after a primary rhegmatogenous retinal detachment. And I thought it was unusual because we had a PVD present. The patient didn't have any other risk factors, didn't develop CME after the retinal detachment repair. And so I was wondering if there was anything that I could have done differently during my surgery or postoperatively to help decrease the risk of macular hole formation. And then I saw a similar patient done by a colleague of mine who had the same thing happen. And so that led us to really do this case series of patients who developed macular holes after vitrectomy for retinal detachment repair.
And one of the things that I think you're going to stress also is how you look for those preoperative findings that may be important. Macula on, macula off, and a lot of times with clinical exam, you won't realize there is a small pre-existing macular hole. I found really now that I'm using a lot more high resolution swept source OCT on all of my detachment patients. Take me there first before we talk a little bit more about your paper.
Sure. I think that's really important. We tend to get imaging on all of our retinal detachments preoperatively, photos, as well as you said, high resolution OCT imaging. Sometimes, if it is a macula off RD, it is difficult to get a high quality photo all the time through the macula and a good quality photo of the fovea where you might see a small macular hole. But most of the time you can get that area and make sure that there isn't a macular hole or something else. I also look for other characteristics like tons of CME present and the presence of a PVD, which you can assess on your clinical exam, but it's also helpful to have the OCT to really be certain that there is a preoperative PVD as well. We also recently have intraoperative OCT, which I find helpful if I'm doing something in the OR and I'm looking at the macula and think, hey, is there a small macular hole there? I've found that very helpful as well while I'm in the OR to assess for the presence of a macular hole.
So take me through your study to identify risk factors and take us through what you think are the most relevant risk factors for this presentation.
Sure. So, one of the things we wanted to do was make sure that we weren't totally biasing the group of patients that we had in this case series. And so In any case series, there are obviously biases, but one of the ways we tried to handle this was to match our 44 patients who developed macular holes after vitrectomy for retinal detachment with 44 similar patients who had vitrectomy for retinal detachment and did not have macular holes. So we matched them on age and sex, the presence of a PVD preoperatively, type of surgery. So if they got a buccal vitrectomy versus a vitrectomy alone, and then macula on or off, and roughly the quadrants that were detached. And what we wanted to see was, again, were there intraoperative factors that could be differentiated? Type of drainage. So did we use perfluorine? Did we drain through the break? Did we use a drainage retinotomy? Or did we use a buccal or no buccal that could affect the risk for a macular hole to form afterwards? Did we lift the hyaloid, and did we use triamcinolone or Kenalog to stain the hyaloid? So these were all intraoperative factors we looked at. And then postoperatively, we also looked at some risk factors that we thought would be related to macular hole formation, things that might form tangential traction, like the formation of an epiretinal membrane or cystoid macular edema.
So one of the things I find interesting is that I am virtually always now elevating the hyaloid. So if the vitreous is attached, I'm removing that in literally 100% of vitrectomies. Do you guys approach that way, or do you have something that determines when you want the hyaloid to remain in place?
No, agreed. 100% of the time when doing a retinal detachment repair, we assure that either there is a complete PVD or lift the hyaloid completely. Oftentimes, I operate a lot with fellows, so I'll often use a stain like triamcinolone or Kenalog to assure that we have a PVD and to help make sure that we have a PVD. I think it's really important because even that leaving sometimes there's vitreous schisis and you don't notice, and that thin scaffold can be deceiving. And so it's really important to prevent PVR, and also leads to ERM formation as well if there is a thin scaffold left behind.
So you did a retrospective case-matched approach. Tell me what your findings were and whether you were surprised.
Sure. So what we found was that really there were no intraoperative factors that um, were risk factors for postoperative macular hole formation. So there was a slight tendency towards perfluorine use. To those patients had a higher propensity for, there were more patients in the perfluorine group that had macular hole formation than the drainage retinotomy or drain through the break, but it wasn't statistically significant. The most important risk factor for macular hole formation was postoperative CME. And then there was also a higher presence of epiretinal membrane in the patients that formed macular holes, but that did not reach statistical significance. I was surprised by the fact that there was a higher risk of macular hole formation in the perfluorine group. I would have thought that sometimes patients that have drainage retinotomies have higher risk of forming epiretinal membranes post-surgically. But I think that also the patients we might use perfluorine are the more complicated detachments, have a greater amount of retina detached, and there's something else going on there that might lead them to have a higher risk for macular hole formation. I was not surprised to see that patients who had CME postoperatively were more at risk for macular hole formation or epiretinal membrane. And I think that that makes sense, knowing that we likely successfully released any anterior posterior traction, but it was this tangential traction that maybe led to the macular hole.
Yeah, so that's led to, I use triamcinolone acetonide not as a staining agent, but as a pharmacologic agent at the end, because I have also had that same experience where I think that postoperative CME or the formation of epiretinal membrane increases your macular complication rate, either macular hole or visual compromise. So that's one of the ways that I have addressed that. We've talked about it, but not really reported it. When you operate, are you doing that? at the time of surgery? Or are you waiting to see them postoperatively to target potential CME?
Yeah, I don't routinely use triamcinolone or Kenalog at the end of my cases pharmacologically. I do dexamethasone. Um, if I do see post-operative CME, then I am particularly aggressive about treating it with either a subtenon's Kenalog injection or something like that. And now even more so, given the findings of my own study that really kind of confirmed that this is a true risk factor for macular hole formation.
Well, I love that, Dr. Finn, because it's interesting that we read the literature one way, but if it's our patient in our study, it does have an immediate impact on our care. So we don't talk about that very often, but I would agree that's very true. So I think you've done a really nice job identifying what is fortunately not a common event, but you've identified what some of the risk factors are, some of the modulators that we can use after. And I think that has direct clinical relevance both for these patients and maybe broader in our vitreoretinal surgical group as a whole.
Yes, I think that this has the potential to, I think, inform future studies as well about what we can do to prevent such occurrences in the future.
Well, thank you very much for joining us. A very nice conversation, and people can go directly to the manuscript for even more details. So, Dr. Finn, thank you for speaking with us this afternoon.
Thank you, Dr. Murray.
Thanks for tuning in to the JVRD Authors Forum. You can watch and listen to more episodes on the ASRS YouTube channel and on popular podcast directories, including Apple Podcasts and Spotify. Visit www.asrs.org/JVRD forum on the ASRS website to learn more. See you soon.